was asked to kind of show a number of case examples and talk about, why I chose to use LITT for a variety of different tumors, and how we think about, who's a candidate, and why, what are the indications to actually use LITT, especially when there are alternatives like open surgery or other radiation, often in conjunction with it. And so I thought I'd go through a few case examples, but I want to make this interactive, so if people have questions as we're going through it, please, feel free. Kind of going through different tumor types and starting with the high-grade gliomas, which we talked about. The way I think about the utilization of LITT in recurrent high-grade gliomas is basically for the preservation of rapidly declining quality of life, right? So most of our recurrent GBM patients, when I counsel all the GBM patients at initial diagnosis, I basically tell them, look, if we can get you through surgery without a decline in function, you're going to have a up and down course during radiation and chemo, and then things are going to stabilize. And that is your best quality of life time until progression. But for most of them, first progression begins a slow and sometimes not slow decline down to lack of function and then death, right? And so as people are declining and they're more frail and they've undergone radiation and chemo already and their KPS is not as good, the appeal of open craniotomy decreases, right? And that's why with the data being a little bit more mixed about the value of re-resection or reoperation, it seems that we should really take the most minimally invasive and minimally damaging approach. And so here's just one example of a 70-year-old woman with IDH wild type, unmethylated GBM. She underwent an initial open resection. We got a nice gross total removal of this tumor. She underwent STUP and did well for a while. So it was about 14 months to her first recurrence. But now her recurrence is more posterior to the original tumor. It's getting a little bit deeper. As we know, these lesions into the corpus callosum come with a lot of cognitive deficits. She's already not great because of the prior radiation and loss of a large portion of her temporal lobe. And so our goal here is to extend life, and I think hopefully I convinced you from the data that I showed you from the RANO-RESECT group that there is benefit even at recurrence for some sort of surgical intervention, but it really has to be balanced against preservation of function and quality of life. And so for this lady, we performed a laser ablation. Because of the size of this lesion, it was 2 trajectory. It's on the border of size in terms of what we think she's going to maybe tolerate without debulking, but you have a little bit of room here because she's had a large temporal resection in the past and she's a little atrophied also from radiation, and so she did tolerate this without the need for resection. Got a nice ablation that then remained stable for about 6 months. We typically will start a second line of chemotherapy. This woman was not in our immediate CCNU, one of those patients, because this was before we were doing that, but she did go on to lomustine about 3 to 4 weeks out from surgery, and then remained stable for 6 months until further progression. And that's, I think what we can hope for as long as we're able to preserve quality of life in a recurrent GBM patient. So this question of what is the value of resection, does keep coming up. The RANO-RESECT data, which I do feel is the best data out there, simply answers the question of do something versus nothing, right? But it doesn't really address the issue of extent of resection at that recurrent time point. And there are a few papers, all retrospective, but I'm partial to this one because I wrote it, where, at my time at UCSF, we looked at a very large cohort of patients retrospectively and volumetrically assessed gross total resection at initial surgery and recurrence, and we used the definition of 98% contrast enhancement as gross total. And what we showed was that the extent of resection at recurrence really matters for patients who initially had a subtotal resection, who had a substantial burden of disease prior to their initial radiation and chemotherapy. But if you had a gross total resection and went on to full stoop, you gained the maximum benefit already in that period between initial treatment and first progression. And resection probably helps. I mean, all these patients, even the subtotal ones, we're still talking, we're in the kind of 80 to 90% range, but you don't have to achieve a complete resection to see that benefit. In fact, there isn't a statistical difference based on the extent of resection at recurrence. And this is important because with LITT, we rarely get 100% coverage, especially of recurrent gliomas, because they recur in such a odd and invasive pattern. It's hard to ablate the whole thing without causing significant neurologic morbidity. And so, if you can get most of it, I think you're still giving the patient a benefit as long as you're not causing a deficit. I mentioned earlier that there's also biologic benefits to combining LITT with chemotherapy and immunotherapy, and there are 3 clinical trials that are ongoing and have not yet reported their results, although we've seen hints of that 3rd trial, which started at WashU and completed in Florida, that there is some benefit to combination of immunotherapy plus LITT at recurrence, and hopefully we'll see that paper in the near future. It's submitted. Okay, good. But based on what I've seen, I'm very excited to see it come out in publication, because I think it will show benefit there. What about newly diagnosed high-grade gliomas, right? So there, it's a little different, right? In the recurrent patients, I think LITT is good because they're frail and can't tolerate surgery. In the newly diagnosed patients, I select the patients who are actually the most high functioning for LITT, where I worry about deficits that are going to come from an open resection. So here's a 65-year-old man who is a very highly functioning and completely cognitively intact gentleman who just had a single seizure and was found to have this glioblastoma. And in this location, I can assure you an open resection will always lead to a cognitive deficit, right? On our office exam, he's going to be neuro-intact, right? He waves his hands, he's oriented. How do you feel? I feel good. But if you do neuropsych testing, you're not getting away with this one. And largely, it's because of the approach, right? Because what's in the tumor is dead. He probably has some deficit already, but when you're not causing a deficit from inside the tumor because that's necrotic. You're causing it from the damage to the functional tissue around it. And so for him, because he was so high functioning, I opted to do LITT. But he did have significant mass effect associated with this, so this was one of the pre-planned LITTs and then tube-based, minimally invasive resection, and he did great and returned to work, almost immediately and worked through radiation and chemotherapy and was really doing fantastic. Unfortunately, you can't fight the biology of this disease, and so 11 months later, this happened to him. And so his survival doesn't look very good because he declined very quickly after that. But I don't know that an open resection versus what we did would have made any difference for this because it's just a very aggressive invasive tumor. How about low grades? Well, for low grades, for me at least, it becomes about location, but also the diffuse nature of low grades. Right, so here's a 26-year-old gentleman that came to us again, just with a first-time seizure, no neurologic deficits, and this is a massive tumor. This, the imaging here doesn't really even do it justice, but it's incredibly invasive. It's basically covering the entire extent of the cingulate gyrus and crossing, of course, right under motor and sensory. So this is an incredibly hard tumor to resect openly. Normally if I were going to do it, I would come in through a superior parietal lobule approach and come under it. But with the cingulate gyrus, in the posterior half, you're almost certainly going to get an SMA syndrome, actually, because there is connection there there is pass-through for motor there. And so, we opted instead to ablate this. And it was a subtotal ablation. Thankfully, this was a grade 2 oligo, and so he's also going to be very responsive to systemic therapy, but we ablated a lot of it, And this is an example of one of those patients who declined on me. So I put him in the ICU, and I knew I was going to resect this. And I scheduled him for a 48-hour post-ablation resection. But the night after the procedure, he basically began to herniate. And I took him to the OR in the middle of the night to do the resection. But the outcome, worked out quite nicely, and we got a lot of mass off. He did end up getting adjuvant treatment with radiation and PCV because of the remaining residual, and now he's 3 years out and doing very, very well with no recurrence. And so I think that, again, this is one where surgery alone is a guaranteed deficit here. The goal of this was to minimize deficit, but you got to consider mass effect. Here's a patient we just treated a few weeks ago, so a 48-year-old woman with seizures, non-enhancing low-grade tumor basically running in the hippocampus. The treatment for this is basically just like a mesial temporal lobe epilepsy case. It ablates very nicely. It's sort of perfectly set up for LITT, and there's no way to resect this thing without causing some damage on your way in, as was discussed earlier with temporal lobectomy. As mentioned multiple times today, this is her immediate post-op scan. You can see everything we ablated enhances now, where it didn't before. So this is definitely something that you have to prepare for when she gets brought up a tumor board and somebody freaks out that it's now enhancing. What about brain mets? So this, to me, is sort of the prototypical case for LITT. You have a patient with metastatic disease, in this case lung adenocarcinoma, multiple lesions that were treated with radiosurgery, and then, as frequently happens nowadays, they go on systemic immunotherapy, and one or multiple lesions kind of blow up on you. We know that there is an association between pseudo-inflammatory responses like this and systemic immunotherapy, and you can treat the edema, which can be massive, with steroids, but then that's somewhat counteracting their systemic therapy. And so for these patients, for anyone on immunotherapy, for suspected radiation necrosis, my goal is always to ablate them with LITT in order to get them off steroids quickly and back onto systemic therapy. And this is, pretty typical. We get a nice ablation, and then over the course of several months, the lesion involutes, and pathology on this demonstrated that this, as you would expect, was radiation necrosis. But now I'll pose some cases to you. So here's another patient, metastatic breast cancer in this case, had a lesion on the left side periatrially there that was treated with radiosurgery in September 2022. And about 5 months later, she starts to have some minor growth there. We decide just to watch it. Another 6 months later, it's gotten a little bit bigger, but as we do for all our cases, we get perfusion imaging, and it is stone cold, non-perfusing, right, or hypoperfusing. So what do you think this is, based on time course and imaging? I mean, obviously I'm asking this question for a reason, but we suspected that this was, slowly trickling radiation necrosis, and we planned laser ablation as such. But as always, we always biopsy because you have to know what you treated. And in fact, her biopsy demonstrated completely viable recurrent adenocarcinoma, right? Here's another patient, 62-year-old man with ALK mutant lung cancer, treated with radiosurgery for this left temporal lesion, and then did great for years on alectinib systemically. 2 years post-radiosurgery, this thing suddenly blows up like this. Okay? It's a pretty long time after radiosurgery for radiation necrosis. So we were assuming maybe recurrent disease, maybe he's now become resistant to his ALK inhibitor. And this is a very surgically resectable lesion, but he, didn't really want to undergo a craniotomy, and so we offered LITT as an alternative, which he was very happy about. We ablated this thing 3 months post-LITT. It's, very much involuted, and his pathology actually showed radiation necrosis at over 2 years, and I still follow this guy now. He was the first patient I treated at UC Davis when we started the LITT program there, so he's now 5-6 years out. and no recurrence as you would expect for radiation necrosis, but we would have guessed wrong on a lot of these cases. And so, we went back, and this is a study that is now under review, but I had, the residents go back and look at a grouping of patients. So we had 41 patients with progressive lesions after SRS for brain metastases, of which all of them underwent a biopsy and LITT, and so we had ground truth pathology of what was going on. 25 of them ended up having radiation necrosis, 16 were recurrent. And then we gave all the imaging to our most senior neuroradiologist blinded to what it actually was, and we asked him to use everything, including perfusion imaging, to tell us what he thought was going on based on the clinical history and the imaging. So he misidentified 29% of cases, incorrectly calling 20% of radiation necrosis cases as recurrent tumor, and even a higher percentage, 44% of recurrent tumor as radiation necrosis. So I know there's a belief out there that perfusion imaging and even maybe with PET and other modalities are really good for determining this. There's delayed contrast MR as well, and I think they are really good. And if you combine the modalities, you get closer and closer to 100%. But nothing is as good as biopsy. And so nowadays, when we have any inkling of a diagnostic question, I biopsy. And if you're going to biopsy, you're already halfway to ablating. And so because LITT is beneficial for both radiation necrosis and tumor, it's why we're treating so many patients these days with biopsy and LITT. And so my approach here is really, if you're 100% sure that it's clearly recurrent tumor, of course, you can reirradiate if they can handle that. If they need debulking because of mass-related symptoms, you can do a craniotomy and reirradiate. Or you can do LITT, and based on the retrospective data and the upcoming data from Remaster, we always reirradiate after LITT. If you're 100% sure it's radiation necrosis, you have a number of different options, but LITT is going to be the fastest and cheapest resolution compared to Avastin at least. But if your pathology is unclear, yeah.
Mm-hmm. Did you get any pushback from the broader care team when you started talking about earlier biopsy, just in terms of the risk of the biopsy?
So surprisingly not. With all these things, the more you talk about this with your team and the more you bring this up, and I think after you have a few case examples, after you treat a few patients and present their outcomes at tumor board, you start to actually get a lot of interest, because the radiation oncologists like LITT because it doesn't inhibit anything they do. It enhances. Most of the time, you're either fixing their radiation necrosis or you're going to do LITT and they're still going to radiate. The medical oncologists love this because they always want tissue, right? If they can send tissue for next generation sequencing, they're thrilled. They want to biopsy everything. And so I find, at least now, a few years, several years into it, more often than not at tumor board, they keep asking me to LITT things that really shouldn't be, right? I get more requests to do LITT on cases that I don't feel comfortable with than have trouble convincing people that we should treat the cases that are appropriate. And that's why, when pathology is unclear, and I would argue that it's unclear more often than you think, biopsy plus LITT, is the obvious answer because it works no matter what situation you're in. Just very quickly, a couple of other tumor types. We've talked about meningiomas. We had this patient, 6-year-old with NF2, multiple meningiomas, but a really huge intraventricular meningioma that underwent 2 debulking procedures that were subtotal and continued to recur. Because of his young age, we didn't want to radiate him, and so his family actually sought out alternative options and approached me about potentially doing LITT for this. This is a big lesion and it's intraventricular, so it's surrounded by CSF, which can be good and bad, but in this case we planned a dual sort of crossing trajectory to get this whole lesion, and I actually made small eyebrow incisions for him. And so we went transfrontal, which is a really good approach for either central anterior tumors and kind of through the forehead to go for insular lesions. And this way we kind of masked the scar a little bit for him in the eyebrow, and got a really nice ablation on this. You can see sort of the change in character of the tumor immediately after the ablation. This was done in the last 6 months, so I can't give you the long-term follow-up on this, but this was kind of it wouldn't have been my first choice for dealing with this lesion, but because we were limited by multiple prior surgeries, not really a radiation candidate, this was kind of a salvage decision. I think other tumors, we've treated quite a number in both adults and children, posterior fossa ependymomas and medulloblastomas after conventional treatment. So here's a 53-year-old woman with a grade 2 ependymoma. It had a large lesion, had a posterior fossa crani and radiation, and then a few years later had a small focal recurrence right near the fourth ventricle. This is a small lesion to undergo a repeat craniotomy for, and you're going to have to dig for that, right? So it would be a big procedure for her for this, small recurrence, but it's sort of a perfect target for LITT, right? And so we ablated this lesion, and she received no further therapy after the full ablation because it is low-grade ependymoma, and really, actually, there's not a good chemotherapy anyway. And 2 years later, she's still, controlled at that site. So basically, in summary, I think that there are lots of applications for LITT, high-grade gliomas, low-grade gliomas, METs, and a mixture of other tumors. The main things that kind of help me decide when I want to ablate a patient is, I think about the frailty of the patient and what the consequence to them would be to undergo surgery and the potential deficits there. And so I think of LITT as actually for both ends of the spectrum. It's for the super high functioning patient who you want to maintain high functioning, and it's for the very poorly functioning patient who really has no physiologic reserve and you don't want to make any worse than they are, because at that point it's not worth the treatment. And I think you can utilize it in that way, but again, it's been said many times today, remember the mass effect. The mass effect issue is humbling, and if the goal is to maintain functional status, you'd be surprised how quickly people can decline from the edema, which can happen immediately the day of the procedure, or more often it happens a week or two afterwards after they've tapered off the steroids.
How much mass effect reduction do you get with meningiomas long term? Like, the mass effect is part of the issue.
Yeah, so it's mixed. They definitely do involute after the ablation. If a patient is really symptomatic from mass effect from a meningioma, and often those lesions also have a lot of edema around them, right? Because they can be very large and asymptomatic. It's once they start causing some edema and their biology that they usually get symptomatic. I don't know that LITT would be my go-to for managing that. I mean, I still think meningioma especially is a surgical disease. Where I've used it is, again, in frail patients. So I had a few elderly patients with really intractable seizures from higher grade meningiomas who'd undergone resections before, were on multiple antiepileptics, and really getting knocked down by the drug effects. And we ablated, and you often will not get a true gross total ablation on those, but it was enough to give them better seizure control, which was really the goal. And then a few patients with high-grade, anaplastic meningiomas who had undergone multiple surgeries and radiations and had, now free flaps for the closure and all that, where they just kept recurring. Another surgery was out of the question. We weren't going to raise that flap again that barely healed the last time, and they were maxed out on radiation. We would use it as kind of a salvage.
I was wondering what your thoughts were. That younger patient that you had to take emergently for the low-grade glioma, what are your thoughts on staging the LITT? Because I feel like with the low-grade gliomas, you could probably just burn part of it and then give them some time to cool off and then have them come back and just sort of serially go through it.
That is a great thought, and in retrospect, that's absolutely what I should have done. That was, early experience, and that was the first patient for me that really decompensated after LITT. And I thought that we would get away with it because it was low grade. I mean, I guess that's the lesson from that case, is it makes sense on the high grades because they already have so much edema and so much mass effect and shift. But this guy, despite the size of that tumor, really didn't have any midline shift, right? As we often see with the very large low grades, they're tolerating the mass effect just fine and don't have headaches and are not symptomatic. And so I thought that he wouldn't develop as much post-procedural edema either because it was low grade, and I was wrong. He really swelled up afterwards, and that's what led to the emergent surgery. So, again, be humbled by the edema. Have a plan for the edema. And now everybody gets mannitol in the OR, even the smallest lesions. I give everybody mannitol at the beginning of the case, and everybody's on steroids.
Could you argue the opposite, that a necrotic center in a high grade is more amenable to have less swelling when you ablate it, as opposed to a tissue-filled low-grade glioma?
Well, remember that the swelling is probably inflammatory in nature, right? So it's likely cytokine mediated, and so in high-grade gliomas, that massive amount of cytokine and broken blood-brain barrier and vasogenic edema is already there from the tumor. In the low grades, it's not, but the thermal injury is causing it, right? The cell death is leading to inflammation. But I think they both have it, but for different reasons.
Several of you guys have mentioned PEDS cases, that you're obviously doing some. Is there anything to take into consideration different in a pediatric patient? I mean, I would think the edema actually is a higher risk because their brain is tighter in general, but...
Yeah, I mean, I think it ultimately comes down to the underlying pathology. I have some pediatric experience, and it's mostly been with posterior fossa tumors, so mostly residuals after surgery for medullos and ependymomas. And I found that those kids actually tolerate really, really well. I think that there's sometimes fears about the probe sizes. Before we had the NB3, people thought that the 3.3 millimeter probe looked huge in a little pediatric brain. But they tolerate it. It's the same size as an EVD, and we put the same EVDs in kids and adults. There isn't much tissue disruption from the probe going in. And now with the NB3, which I personally like, it's a very small probe too. And so I haven't found those cases to be really any different than adults.
I'd say your intuition could possibly be, I don't have a pediatric practice, but pediatric neurosurgeons I know sometimes will be like pretty strict about 2 weeks of Decadron prior to a treatment, which not all adult necessarily cases maybe need. So just, be aware of that.
I mean, as routine, all of our peds patients do go to the PICU after this procedure because, anytime we do anything invasive on the kids, we're super cautious.
The post-ablation enhancement, does that last forever, or does it go away, or?
So it will regress, but there will probably be some gliotic scarring there. So I've rarely seen any tumor that I've treated, even if you follow it years out, have nothing there. There's always going to be some spot of enhancement at the site that you treated, but it's not going to look like it does immediately post, right? So what you expect to see post lesioning is, a rim of enhancement at the boundary that usually corresponds with the yellow TDT line, and then mixed kind of internal contents, which are mostly, hypo-intense, representing necrosis, but you do get coagulation in there. And so the clotted blood has some intrinsic T1 shortening inside the lesion. And then over time, that actually worsens. So most lesions will expand even over the course of weeks to a couple months, but the center will become more necrotic, and the overall volume goes up, and then it involutes.